by the side. In the middle picture, you can see that, in the middle picture, you can see that the contralateral ports are being used by a surgeon, and this position is also known as a flying bird position. And as humans, we are not bound to fly. So this is a lot of difficulty for the surgeon to suture. Again, on the right picture, you can see that ipsilateral ports are being used, and the surgeon is comfortably standing with the elbows besides the body and the angle of 90 to 110 degree, and resultingly having much more dexterity and ease of doing the suturing. So the equipment which we need to be familiar of, or which we need in our OR to start laparoscopic suturing, obviously we need ports to transport the instruments, and then we need to have a needle holder, and then we have to have another assist grasper in our left hand. That this could be another needle holder as well, and this could be a proper assisting grasper as well. And sometimes we use bowel graspers as well. So we need to know about the surgical needles and the sutures as well. And about the optics, yes, we need to have HD system. 3D system is a very good system, and usually we need telescopes of 30 degree and 45 degree to assist us in the laparoscopic suturing, because it's a dynamic suturing. Suturing is a dynamic process, and the camera has to change and show us 0 degree is usually not very good and conducive in assisting the laparoscopic suturing. So now these are the ports. We have both metallic and disposable plastic ports, and these ports come in various sizes like 3 mm, 5 mm, and 10 to 12 mm. And these have valves or caps, and usually we like to have a tri-valve which can allow 3 and 5 mm instruments, and with a rubber universal adapter. However, the metallic valves, they are not good for extracorporeal suturing, though they, with the reducers, they can easily allow the 5 mm and the 3 mm instruments to go through. And usually the new plastic or the disposable instruments have a transparent sheath or outer sheath, which is easy to find needle in the trocar, and both while retrieving and inserting the needle into the body. So usually we used to apply a 5 mm port for the suturing because it gives precision, because in a 10, 11 or 12 mm port, there's a lot of swiveling around the needle holder. But on the other hand, in the 5 mm, sometimes there is a lot of friction as well, which hampers your movement as well. So you need to be well versed with both the ports, 5 mm and 12 mm, how to use them while doing the suturing. So now coming to the needle holders, which are the most important instrument while you are doing suturing. And then if you see a needle holder, which was rather shown in the video before, it has jaw, it has a shaft, it has a handle. The jaw, usually there are two types, curved and straight. Both can work fine. My personal preference is curved, because the groove in the curved needle holder can easily facilitate the housing of the loop of the thread while knotting. So when it comes to universal or versus self-writing, I would prefer a universal one, because wherever you in the abdomen you are doing suturing, sometimes the wound is not appropriate, the ports are not horizontal. So self-writing will automatically place a needle in a single or a prefixed plane, that is 90 degree T plane, which is called. And whereas in universal, you can rotate the needle as per the jaw of the needle holder from 90 degree to 135 degree, and can adapt to the wound and do a proper suturing. So the surface of the jaw inside usually is tungsten. It has to be secure, but it should not be so much traumatic that it should deform the needle or also fray the thread. Then micro versus macro, these are 3 mm versus 5 mm, and sometimes the shaft, the important thing in the shaft is that it should be of that material so that minimum glare should be produced, so that optical or the strain on the eyes of the surgeon is minimized. Now coming to the handles, there are two types of handles, curved and versus straight, or the pistol. I think you can see my cursor as well. The cursor is on the straight one, and then now the cursor is on the pistol grip. Pistol grip is very ergonomic, but when you are rotating the shaft, so to apply the knot during the loop process, or rotating the shaft to pass the needle, these pistol handle or the curved one, the handles, they are not that good. So most of the times we use the straight handle, and in a needle holder, usually there's a mobile part in the jaw, and opposite to it is a fixed part of the handle. So similarly, the mobile part of the handle is contralateral to the fixed part of the needle holder jaw. So again, there are ratchets and release. The release should be within your forefinger, and yes. So there you see, if you see the needle holder here, if you can see the cursor as well, this is a very, needle holder should be of such good material that it can also handle the 8-0 or the fine needles as well. And there you can see the finger release is just properly suited so that a surgeon with the index finger can easily release the ratchet to the maximum and to the minimum so that he can manipulate the needles. There is a difference why I said so that I like the universal. I don't like the self-writing, or rather not prefer the self-writing needle holder. Like is a strong word, or dislike is a strong word here. In laparotomy, you can see that you have a 360-degree movement angles, whereas in laparoscopy, we know that only 4 directional movement can happen, and 3 to 5 degree angle is available to the surgeon. So there, if you see the cursor here in the photograph below, if I have a universal, if I don't have a self-writing needle holder, I can adjust the position of the needle holder, the T-plane, which I will explain in the coming slide, from 135 degrees, so that I can rotate and I can have a variable depth of the tissues, and I can also place, if I cannot place the needle holder horizontal to the wound. So now coming to the assist grasper, this is a very good instrument, and the best thing about the assist grasper, any grasper which you're using, if it's a needle holder as an assist grasper, or it's a bowel grasper, it's a proper assist grasper, that it should open, and the hinges when it jaw opens, and it should be usually a one-way opening jaw. It should not be two-way opening jaw, because it will create a lot of problems by entangling the thread or the loop, and also minimizing the vision of the surgeon as well. So these also come with a straight versus ratchet, and obviously straight handles are better, without lock are also better, and obviously they need to be glare resistant as well. So here in the top right, you are seeing a 3 millimeter mini laparoscopic assist grasper by the Co industry, and then there you see in the on the upper side, you see a proper 3 mm jaw, which is not traumatic to the suture and the needle both. Whereas if you see the below, it's a 2 mm grasper, but it has the surface of the jaw is very rough, and it will not only deform the needle, but also cut the suture as well. It's not a good, and also will damage the surrounding tissues as well. So the upper, this one is the preferred one. So coming to the needles, in the gynecology, there initially straight needles were being used, and there were ski needles which were used half curved because they were easy to insert and easy to retrieve. But nowadays, the curved needles are being used, and when they are half circle needles and they are circular taper needles, so they need to be introduced by backloading, or they can be introduced directly from the 10, 11, or 12 mm trocars. Then the size, most of the time we are using this half circle, and sometimes we also use these 3x8 circle for as well. And these are usually made of titanium, and they are pretty good strength, and the needle holders are also quite adaptive, so that these needles don't get deformed or broken off in the human body while doing, because it will be difficult to retrieve them. So straight needles, why don't we use straight needles very commonly? Obviously, we use this for fixation of organs because they only work in 2 dimensions. They work in a translational way. They use the fulcrum, so have a forward needle driving and side to side suturing, and then you can't have a full depth suturing with a straight needle. And then you need central ports, which are not very ergonomic for straight needles, and usually we only need it for suspension of uterus or ovaries during the pelvic surgery. So curved needles, these are the mainstay of the intracorporeal suturing, and as you can see in the picture on the right side above, that they have a rotational axis of movement. And then when you, these also have similar movements are we can have laparoscopically as we have in open surgery. Obviously, the hand will be moving outside in a counterintuitive manner, but inside there's the movement of the needle holder with a curved needle is similar to that what we use in open surgery. And then this is there is a rotational movement on the needle, then the shaft can be rotated. So there's another axis movement which can give you in the sagittal plane the vertical suturing, and then there's a forward push of the needle. So these three, these together combine to form the rotational movement that we get with the curved needle, and then we get variable depth of the tissue bite with these needle as well. So coming to the preferred needles, if we see, usually I have made this table, circular taper needle, which is half circle, usually between 26 to 36 mm size needles. They can be used for hysterectomy, cuff closure, myomectomy, and sacrocolopexy, and the colpopexy in the stress unit incontinence. And then this is the small half circle needle. It is also used in myomectomy and cystotomy repair and cystectomy repair. Mind you, these CT1 and SH needles, they need backloading or 10 to 11 mm trocars for insertion into the abdominal cavity. Then there's a round body, the smaller needles. These can be used for serosal repairs, and they are usually 3 by 8 circle. That if you divide a circle into 8 parts, there the needle is only 3 parts of that circle. So there's another needle which is very good. The code name for this needle is BV1756, usually by Ethicon, and this is a Prolene suture. And for fine tubal reanastomosis or vascular repair or ureteroenterostomies or stitching the ureter, these needles are very good. And they are made of titanium and very strong, and they can be even, they not necessarily need a 3 mm laparoscope. They can be even used with a 5 mm, but it's better to use a 3 mm needle holder with these needles. So coming to the needle anatomy, it's very important. If you see a needle, there's a sharp end of the needle point, which can be round body, which can be taper cut, and which can be cutting as well. So needle is basically divided into 3 parts, and there's a PB, PM, and PX. PB is the distal part, which is the demarcation of the distal 1/3 and the middle third, whereas the PM is the M stands for middle, it's middle of the needle as well. And then the PX, which is distal 2/3 and 1/3, and then towards the thread side, that is known as swatch, where the thread is attached. So these are the points which a surgeon must remember. The thread 2 centimeters away from the swatch is also known as the A point. And if you see these 3 points and the 2 centimeters from the thread, these are the points which during the surgery, a surgeon should apply the needle holder or the assist grasper on these points to load a needle, to drive a needle. So we will see that in the coming slides. I think there is some problem with this today, that I can move certain number of slides and then it gets stuck again. Okay, so what I do is I stop sharing the screen again. And then again, I share the screen here.
Sir, yes, you can share again. Yeah, we can see.
Yeah, but it's not moving again. Although this time I can share and unshare. Yes, now it's moving. Okay. Now coming to the sutures and threads, they are synonymous. Basically, we need to choose suture as what our clinical goal is, what we are doing. For example, in a bladder, if we are going to do a repair, obviously we are going to do a absorbable suture. Similarly, uterus is going to be absorbed with a absorbable suture. And then the choice between natural and synthetic, usually non-natural are not used anymore, synthetic are usually used, and we prefer monofilament sutures. But we need to be careful because the braided multifilament sutures can be used as well, especially when you're going to use diathermy in proximity of the suture line. Because if you have used a monofilament suture and you use a diathermy, these monofilament sutures are not very receptive to any sort of heat or thermal damage, and they are easily damaged. So be careful when you're using monofilament suture. Don't use any energy source near them. They are easily damaged by any energy source. So usually what we see is that Aatif bond is used for the colpo suspension and the sacrocolpopexy, and then we use absorbable monocryl for the bladder repair, and then we use proline for fallopian tube reanastomosis and also vascular repair during pelvic surgery, which I will discuss at the end, why a vascular repair can be done during a gynae procedure. And then PDS is now usually the preferred suture for all other types of repairs, and it's now being more and more commonly being used by the surgeons worldwide. So coming to the steps of laparoscopic suturing, there are 5 steps of laparoscopic suturing: insertion of the needle, loading of the needle, and then driving the needle and the thread through the tissue, and then knotting these sutures, and then retrieval. And the most difficult thing to master by a surgeon is the loading. People think it's the knotting is the difficult thing, but knotting is not that difficult. You can learn, but the inexperienced surgeon has real difficulty in loading the needle and how to appropriately load it, because if you don't load the needle appropriately, you cannot suture or drive the needle as you intend to do it. So this is very important. Now, loading the needle, there are 4 techniques which are very commonly used. Lay on the tissue where the needle is lying on the tissue, and then the fixed part of the needle holder is placed just beneath the needle, and then when the mobile part of the jaw of the needle holder is closed, it automatically awakes. I have not shared these videos because I was given 20 minutes, so I didn't want to go beyond. These videos are freely available on web search, on YouTube. You can download them and watch them and understand them. So the other techniques, which is puppet technique, surgeon holds the string like a puppeteer, and then there's the flake point where you can use the thread 2 to 3 centimeters from the swage, and then you can do load the needle or change the axis of the needle. And then there's an expert technique with expertise. You can directly grasp the needle with a needle holder, which comes with a time. So what is a perfect stitch? It's the theory of parallelism. When you are going to do suturing, you must place your needle holder horizontal to the wound. Okay, the axis of the wound is here called F. And if you can see, there's a P axis, this is a needle holder. They should be ideally parallel to each other. And then if the T plane is the angle of the needle in the jaw of the needle holder, which should also be at the tip of the jaw of the needle holder. If it is 90 degree and the P axis and F axis are horizontal to each other, a simple rotation is good enough. So if it cannot happen, then obviously when you achieve the horizontal planes, then you can do a vertical suturing in the sagittal plane, which is also known as vertical zone suturing. So the perfect stitch theory of parallelism, you have to place the needle holder horizontal, or the needle should have a T plane which is horizontal. And for this, these usually in the pelvic or the gynae surgery, ultralateral ports are employed, which I will tell you in the next slide. And if you can see the picture here, this is a similar technique or skill which we use in open surgery. In laparoscopic surgery, except for the counterintuitive movement of the surgical hand outside the abdomen, inside the abdomen, the instruments have to be moved similarly as in the open surgery, and we need to understand it. There's no such difference. The difference is outside the body. Inside the body, they move in the same way. So this is the ultralateral port, or the horizontal to place the needle horizontally. So there you can see in this picture, you see that the anterior superior iliac spine, they are employed. Even in obese patient, you can palpate them, and 1 to 2 centimeter laterally. After developing the pneumoperitoneum, obviously these ports are placed, and these ports, when placed in these areas, they also usually do not involve the area where the vessels are, like inferior epigastric. And then the paraumbilical port has to be placed, and this paraumbilical port can be at the level of the umbilicus or the optical port, or it can be moved up and down depending on the size of the abdomen of the patient. And then you can see that there's a picture below which is showing in the human how these ports look. And these ports can be placed on the both sides. The surgeon can work from both sides, from right and left. It's his or her preference to stand on which side. And if you see that when the surgeon is standing like that, then he can get maximum dexterity because he has maximum control, because the elbows are snug with the waist and they are not like this. Okay, so you have a maximum control, and you don't get tired, and you can easily perform suturing. So this is the way where you can place the needle holder horizontally to the wound axis. So coming to the driving the needle. So we are always do an imaginary overcorrection or do a shadow praxis of the imaginary line when you have a needle in your needle holder. And there you can see that in this picture, if you can see my cursor as well, the needle, the T plane is 90 degree and the needle holder is also horizontal to the wound. So simple rotation of the shaft will get the full bite of the tissue and the needle will come out at the intended point. But however, if we see that due to some problem, if the wound is not placed horizontally, despite moving the table, despite moving the uterine manipulator, then you have to adjust the T plane in the jaw of the needle, and then you can bring the needle at 90 degree to the wound, and then you can use this rotation to pass the needle. So, and then the depth of the bite can be varied with the rotation. If you grasp the needle intermediate, you can have a full bite. And if you grasp the needle near the tip, then you can have a shallow or serosal bite of the tissue only. So coming to the knotting, there are two types of knotting. We are discussing intracorporeal knotting today, but it is always pertinent to compare these two. Initially, the laparoscopic surgeons were using a lot of extracorporeal knotting, and they were using very little intracorporeal. But with time, they have developed, we laparoscopic surgeons have developed our skills. And now, if you can see, extracorporeal knotting is, the pros is that it's easy and it's able to maintain knots under tension. But on the other hand, the demerit is that it can cause excess tissue tension as well, and it can only apply interrupted suture. So it will be a lot of time consuming if you want to do vaginal cuff closure with extracorporeal knotting. So what about intracorporeal? This is versatile, continuous, and both interruption can be done, and even cinching, which was done usually with the extracorporeal, now also can be done with intracorporeal suturing as well. So the rather reduced tissue tension, the appropriate tissue tension can be applied on the vascular bowel. And the thing is that these bowel and vascular or the tubular structures, they have to be coapted. They can't override each other. Like the vaginal cuff, it can override each other, but bowel or vessels or the fallopian tubes or the ureter, they have to be coapted nicely. So they involve the similar technique as in open surgery. Yes, they are technically challenging, but as we have mentioned, if there is a methodical program of training, these challenges can be overcome. And yes, it requires a choreographed approach because you have to rehearse and rehearse and rehearse. Choreography, if you see movies and films where there are dances and there are musical films, those actors and they go into a lot of practice before the real shoot is taken. So similarly, this choreography is applicable to the intracorporeal suturing as well. You need to spend a lot of time in dry lab, and in certain papers it is written that at least if you have to do a skill 20 to 25 times a day for 25 days, then you can say that you can travel the journey from novice to mastery of that skill. And sometimes we say that 30 hours are here. So I have just found out that the cursor on the laptop are not working, but if I click the mouse pad, the screen can be changed. So every day we are learning something. So suture length usually for intracorporeal is 10 to 15, and for extracorporeal is 75 to 90 centimeters. So intracorporeal knot technique, I've just mentioned here 3 techniques. There are many techniques. Gladiator technique, EXPERTC technique, SMILEY technique. There is also a noodle technique. All these videos are available on YouTube, which you can watch and learn. For example, there are a few important things. When you are doing intracorporeal suturing, your ports have to be placed such an elevation angle that their manipulation angle and the azimuth angle they are so coordinated that they don't go beyond the area where you are doing suturing, and that area is known as home. So you need to stay near the home base. If you go away or which you go near, it will be ergonomically difficult to wrap a loop around a grasper and do a knotting. And similarly, if you can see here, you need to make the thread over the area you need to stitch like a horizon, so that you can do a gladiator knot or you can do a C loop knot. This has to be done, and all these are available in videos. And the another thing is that keep your short tail short. Don't keep it long. It should be like 2 to 3 centimeters, and also don't keep it too short. Then you won't be able to grasp it and apply the knot as it should be applied. So this is a brief video of a gladiator knot. You can see there's a C loop, and then there is an open jaw of the instrument, and then you can see the thumb up. The emperor in the Roman era used to say after the gladiator fight whether the gladiator is going to live. They used to say with the thumb up and whether he would die. So in this suturing, you see the instrument first lives and then it dies, first lives and it dies, and it completes the knot. So this is an open jaw rotation. So again, EXPERTC technique, if you see, there's a C made with which the concavity of that is also facing towards the short end. And then you can see that this can be reversed, and then a flat knot can be produced. So this is EXPERTC, and EXPERTC is just similar to gladiator, except here that the jaw is here closed, and there people call it many ways. Either you can wrap it, or the instrument come, jump in and jump out, and so that the loop is entwined around the shaft, and then jaw opens up and catches the short end, and then you cross the thread so that you can have a flat throw. So coming to the SMILEY technique, this is very important to learn, because sometimes at the end of the suturing, your thread is short. So what you do is you place the needle, if you can see in the video, in a manner that you can use the needle also as part of the thread length. And mind you, you need to be very careful. The most dangerous part of the needle in the body and the abdomen is when it's in an instrument or in a needle holder. The needle is really lying in the peritoneal cavity, it will not cause any problem. But if it's in the instrument, and the other thing is that while applying this SMILEY technique, you should have a curved dissector in your other hand as an assist grasp, because the curved side of the assist grasp orientates the thread and the needle parallel to it, and the groove of the curved dissector can easily wrap the loop up, so that here you see the loop of the curved dissector can easily wrap it up and you can grasp it. If you have a other normal assist grasp, it will be difficult to wrap the loop around the thread. So these are some technical tips. So nowadays, these are the barbed suture. These have made the job of the surgeon a little bit more easier, so that you can apply these barbed sutures. These are barbed sutures, have barbs which are unidirectional, so that the thread will move in one direction. Once you have applied it, usually it will not move back. So you don't need to throw a knot at the end of the suturing. Obviously, at the start, you have to pass it through the loop so that it gets fixed. And they are pretty good, but a word of caution for the beginners. If you are a beginner, please perfect your suturing with the normal sutures, because barbed suture, if they are applied, they cannot be untwined and they cannot be retrieved as a normal PDS or normal V-lock suture can be. And then you have to cut it all and do the repair, because these barbed suture are usually 6 to 8 times expensive than the normal sutures. So very important thing, if you want to do laparoscopic surgery, even in doing laparoscopic cholecystectomy for a right-handed surgeon, the Caller's triangle moves with the left hand. Similarly, you need to be ambidextrous, and to become ambidextrous is that if you did a gladiator knot or a C technique expert knot with the right hand, you should do that skill again with the left hand on the simulator. And you will see that maybe with the right hand, you learn that skill in 25 times. In the left hand, maybe you need 30 or 35 times. But if you keep on doing it, your left hand and your right hand can both become equally skilled, and you can do good laparoscopic surgeries if you are skilled. Now why I'm concluding this session, why intracorporeal suturing is so much important. The thing is that the modern gynecologist, I'm just have placed here two procedures. One is endometriosis and the other is prolapse surgery. And if you see in the prolapse surgery, all these intracorporeal skills which I discussed in the preceding slides, these are being applied. You can see the pictures. You can see you need ambidextrity while you are dissecting near the levator ani and repairing it, and you need to do interrupted sutures for the mesh fixation to the vagina, uterus, or puborectalis, and then you need to apply continuous suturing to the peritoneum to cover the mesh. And similarly, when you're doing surgery for endometriosis, and we know that endometriosis is a disease which is a very challenging surgery for gynecological surgeons, and more these surgeries are now being done laparoscopically. Now, due to disease process, sometimes, and you need to take out the tissue completely. You can't leave tissue behind. If you leave behind tissue, the procedure loses its efficacy. And while taking out, sometimes you have to take the whole piece or chunk of the bladder out. So a gynecologist must know how to repair the bladder, must know how to repair the uterus these days, because I'm seeing these videos by the gynecologists, and one of the gynecologists shared a video where a iliac vein got opened during the resection of the endometriosis, and you cannot put a pack there because they called a vascular surgeon, but by the time the vascular surgeon came, the surgeon was skilled enough that she repaired that internal iliac vein. So you need to be very good at intracorporeal suturing because it will save a lot of conversions, because at times you will not get help and it is cost effective as well. So this is very imperative. I'm talking about in Pakistan, where mostly the gynae is usually done being open, but in Pakistan, it's high time that our gynecologists should come abreast with the gynecologist of the world, because in intracorporeal suturing, it is very pertinent to mention that all the advancements in intracorporeal suturing has been made by the gynecologist mostly. So this is something, they are the leading, even Vates, which is a gynecologist, is the leading laparoscopic suturing trainer. And another thing which I must mention, gladiator technique. This was invented by an engineer. So when I say there's a mathematical science to apply the suturing, Armando, who developed this gladiator technique, he's not a doctor. And he developed it because he was an engineer, he was good at maths, he knew how to wrap the thread, and he knows the mathematics of suturing. So with this, I end my presentation. And if there are any questions, I'm here to answer. Thank you very much, Imran, for providing this opportunity for me to share my experience of intracorporeal suturing with them. And I always say that it is when you teach, you learn. And I have not done laparoscopic gynecology, but I learned a lot while preparing for this presentation. And to my knowledge, a lot of things were added. Thank you very much.
Sir, so much thanks. Sir Aatif, like always, amazing. And now we have a lot of message from our viewers. It's the best, one of the best presentations. So much thanks, sir. So much thanks. And my request, thanks, really, sir, excellent. And my humble request to all of my viewers, if you have any query, any question, you can ask in chat, and at the end, the professor will answer. So my thanks, and we will go ahead and welcome Professor Amine Haggu, who is the star of today's session. And we are excited, doctor, to hear from your side. Dr. Amine Haggu, she is head of department of gynae in Nikan Hospital in Tehran. Nikan Hospital is one of the well-known hospital in Tehran, and she has excellent experience in minimal invasive surgery in gynae. Doctor, over to you.
Hello, dear all, and thanks for inviting me, dear Dr. Imran Abbas. And I really very happy to see you, dear all, that are working together in this great society. And it's my pleasure to be with you here and to share what we do and what we know about gynecological surgery in our work. Now, can I share